Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Nicholas Rosenlicht. He's a psychiatrist and he's the author of the book, My Brother's Keeper, The Untold Stories Behind the Business of Mental Health and How to Stop the Abandonment of the Mentally Ill. We're going to talk about that book as well as the excerpt from that titled, The Dangerous Shift in Mental Health. Are we clients or patients? Nicholas, welcome to the show.
Hi, thanks for having me.
So let's start by briefly sharing your story and journey.
Well, I'm not sure how far to go back. I had a career before I was in medicine. I was sort of engineering and environmental science. I went to medical school. I didn't think I'd end up in psychiatry, but really found it was, when properly, implemented, very, very effective in alleviating pain in people's lives. Nevertheless, I did start off in internal medicine and ultimately ended up in an academic career in psychiatry with some teaching, some research, and also a lot of clinical care. What really has bothered me over the last 40 years has been a shift, in the profound shift in the way we orient medicine, which is really now around a business model and how we've lost sight, particularly in mental health, but I think mental health is kind of the canary in the coal mine about what are we actually doing for people and why.
All right. And we're going to talk about one aspect of that business influence on mental health, the dangerous shift in mental health. Are we clients or patients? And that comes from your book, and we'll talk about that later. But talk about this excerpt. Talk about that shift between calling patients clients versus patients.
Well, there was sort of a confluence of things, maybe 30 years ago when I saw the smart doctors who thought they were doing the best thing were getting MBAs and becoming administrators. And why was this, our calling shifting to something else? And then I was actually part of a team negotiating insurance contracts for a community mental health center and learned that as we did these negotiations, we couldn't use the term patient. We had to use the term client, which seemed very odd to me. I'd heard it used, sometimes used it, and thought about it. Why would they care so much about calling people clients? And, what does a word matter? And as it turns out, it matters a whole lot because it really orients the way we view people and what our goals with them are. It's basically the monetization of a relationship that shifts the focus from care and alleviating ill to money.
So, as a psychiatrist, when you're seeing patients in your office or in the exam room, how does that shift from patient to client? How does that affect you as a physician?
Well, I'm kind of lucky at this late point in my career that I can kind of craft my practice the way I want in a way many physicians can't. I can charge people what I want, which can be very little. I can largely avoid insurance companies and let patients, they can bill themselves. But I have a discussion about, like, why are you here? Are you here about a contract over finances, or are you here to get better? I mean, since time immemorial, patients have had rights and privileges that others in our society don't. We realize they need care, whereas a client has no privilege except what's negotiated in a contract. And in healthcare, the contracts are all, they're drafted by healthcare corporations with no input from doctors or patients. So why would you choose to have a unempowering, dependent, less than nomenclature used when you're most at need? So I really just sit down with and say, why are you here? What are we here for? And how can I help you improve your life?
Now, when you were having these negotiations with the insurance companies and they insisted on calling patients clients, like you said, to focus this more as a transaction and a focus on money. So, what's the motivation of the insurance companies to do so? The fact that they want to depersonalize that relationship.
Well, there's a lot of things. It means, in another awful term, provider are interchangeable. They're providing a cookie cutter service, and the relationship doesn't matter. So it's very easy to swap out clinicians. It's just much easier to run a business model. When somebody's a client, they're bound by contractual obligations, if there are any, but things like the duty to devote your resources to the patient rather than the client take over. For example, businesses, they have fiduciary responsibility to their shareholders and their board of directors, not to their clients. Whereas physicians have the fiduciary duty to their patients. That's the focus of what we want to get done. And that shifts. And I just saw my colleagues and I, when we were working for companies, you'd think as corporations and healthcare businesses got bigger and bigger, there'd be more a sense of community, but that just wasn't it. Instead of meeting in the hallway, having time to chat and do curbside consults and kind of talk about the focus of what you were doing with that patient, it became business meetings and rushed, and no time for this supportive chatter that keeps us focused on what we're here for.
Have you ever had a conversation with a administrator or someone with that business focus debating that term client versus patients? And if you had and had this conversation, what was that like?
Well, that's sort of why I wrote this book. I did have those conversations, and with colleagues who were offended that you'd call a patient, and people just didn't get it, which is why I sort of wrote the book, to sort of tie all the loose ends about why it does matter. It changes the way we view people, and it really is an insidious shift. For them, especially somebody who is steeped in the business model, like if you're talking to a healthcare administrator or a drug rep, they just don't see what the difference is. But there's a long history of I mean, in just about every society, having realizing that people who are ill have special needs and they require special protections. Clients don't get that, but patients do get that. You're supposed to take care of them.
So the fact that we're talking about this insidious shift to a more business vernacular, how does that affect patients in general? Why should patients care about what they're being called?
Well, I think they want to know that the person they're spilling their guts to, their stories, letting people give them poisons and cut their body, have their best interest at stake. Why would I trust somebody to open my belly or prescribe a pill to me, or I'll tell my deepest secrets to, is actually on my side, right? Who, the end of the day, are they most interested in helping? And that matters. There's this whole thing about the client is always right and then business nonsense. That's that's just not true. It sounds good, but really, who are you oriented with? I mean, businesses themselves can be clients, but they're never patients. We're talking about an individual who is suffering, who wants alleviation from that suffering. Is this person I'm meeting with behind that, or do they have other agendas?
So let's talk about that depersonalization of medicine from patient to client, from physician to provider. And you even said that some of your colleagues don't really see some of the dangers that we're articulating today. But I'd like to hear about that commentary on a broader scope. So what does that say about that current state of medicine and for the state of medicine going forward?
Well, I think it's not good, and I again view mental health as sort of the canary in the coal mine. It's the only area of medicine I know where the term client has been embraced. It's making inways elsewhere, usually in administrators and business people, but where clinicians are actually calling people clients in mental health. I think a lot of it has to do with the stigma around being psychiatrically ill, like to refer to somebody as a psychiatric patient is really scary, and I think it threatens all of us, even the clinicians. And so you think you're kind of being nice to them, but using a watered down euphemism, it really pollutes the relationship, because are you what are you here for? And is this a serious matter? Or are you here to get your hair cut? I think it degrades the importance of what we do. And there's other things about, words matter. They really affect how we think things. And you think that therapists whose tools are words would be the most astute about why it matters, the terms we use. For example, providers during the Nazi regime, Jewish doctors had the term Arzt, which is doctor, taken away from them, and were called Krankenbehandlers, which is basically illness managers or treaters. So the same thing was done on the Nazi regime. It's a way of disempowering the clinician and also taking away the privilege of autonomy, that their needs are put above that of the clinician. It's a way of turning people into commodities, not suffering human beings.
Now, I know that there are some physicians who push back against being called a provider. Now, have you ever pushed back about calling patients clients with even your fellow behavioral health colleagues?
Oh, I've had people really bristle. People don't think about it. They do what their colleagues do. I don't think there's a lot of thought about what does it matter, what's in a name. And I think a lot of mental health clinicians would just think it odd to call them a patient, but that solidifies the stigma around being psychiatrically ill. It sanitizes it, but it solidifies it. And I think people just don't think, mental illness is scary. It's frustrating, especially in our current world where the resources we have to treat are so inadequate. I think anything that makes it a little bit smoother and easier is the way people go. They're sick of fighting with the insurance companies or having reluctant patients. Call people what they want. And honestly, you do. You don't want to force somebody into a term they don't like, but it's worthy. It's worth having a discussion about, why do you want to be called this and what is our purpose here? And client distracts from that. And it also, a client is something, a lawyer helps you with your divorce, your CPA helps you with your taxes. It's help on an external problem in the world. A patient is somebody dealing with an internal problem, and they're the one actually who has to do most of the work. So it takes the burden of the work uh, off of the patient, and often allows people to kind of slide along expecting to be fixed without doing the work themselves. It really takes the focus off what our work is. And this is most true perhaps in psychiatry, but it's true in all of medicine. I mean, if a surgeon cuts on you, you may have, a lot of tissue disruption, but it's going to take an hour or two. The person's got 6 months to heal.
Mhm.
The burden of healing is really on the patient, not the provider.
This excerpt is from your book, of course, My Brother's Keeper: The Untold Stories Behind the Business of Mental Health and How to Stop the Abandonment of the Mentally Ill. Tell us what led you to write this book in the first place.
Well, it's funny. It was an op-ed I wanted to do, and I did it with an MFT therapist about examining why people are calling patients clients. And even we had a conference where a master clinician, had described a lot of clinical cases, and he always used the term patient. He was not a physician, actually. And then when they published an excerpt of this in their news magazine, they changed the word to client.
Mm.
They misquoted him. And so we wrote a sort of a questioning op-ed about why did this happen? Why is it okay? Why can we change the people's names and what you call them? And I went through a long editorial process to have the op-ed published. And at the last minute, the board of this institute refused to publish it, saying it would be offensive to clinicians. And I'm not sure why clinicians would be so sensitive and didn't want to look at it. This was a publication specifically for controversial subjects, but it showed to me just how deep seated people are hanging on to this term client and started examining why. And I think it really comes down to stigma and the courtesy stigma that psychiatrists and other mental health clinicians have. I think we are somewhat reviled for dealing with things and talking about issues that others would just rather not look at. I mean, mental health and mental illness is just ugly sometimes.
Mhm.
I mean, when somebody has having an asthma attack or a heart attack in front of you, you don't hesitate to drop to your knees and help them. When somebody's ranting and spitting, it's often revolting. And I think anything, especially the people who have to deal with this, would really rather hide behind a euphemism. But it's not serving us because it's let a business model take over, which is not serving the clinicians or the patients. I mean, look at the 500,000 people homeless, mentally ill now. I mean, is this the way we want to treat our fellow, human beings? To get care in mental health now, you basically have to be fabulously wealthy to pay out of pocket, or ill that you're basically committing a crime. You want to kill yourself, someone else, or you're so disruptive to society around because you can't provide food, clothing, and shelter. So it's criminality that gets you care, or it gets you incarcerated. It doesn't get you care. This is just not the way I think we should be treating human beings.
So, given that context, what are some of the paths forward for people who do want better access to behavioral health services?
Well, I wrote the book actually for what I hope was an informed lay audience. Physicians, I think, largely know the problem, although mental health has again been somewhat marginalized. Why we have laws to protect against the commodification of medicine and of patients. They're just not being enforced. We have corporate practice of medicine laws in all states, which are to basically keep business decisions out of healthcare decisions. They're just not being enforced. Corporations are not allowed to practice medicine yet. By setting up elaborate shell corporations and organizations and holding the purse strings, they effectively are practicing medicine. I think we need to let our legislators, who actually the healthcare industry is the largest lobbying industry in the United States, we need to make people aware and our legislators that actually this is killing us. We don't want profit to be made off of, suffering and death. The fund that your 401k is in, it's making money by closing rural hospitals that is killing people. Is that how we want to be making money? That maybe the educational fund you have for your daughter is making a lot of money, but it closed the hospital that could have saved her life when she inadvertently overdoses at a dorm party. We need to look at the consequences of our actions, not be so myopic.
We're talking to Nicholas Rosenlicht. He's a psychiatrist and he's the author of the book, My Brother's Keeper, The Untold Stories Behind the Business of Mental Health and How to Stop the Abandonment of the Mentally Ill. Nicholas, tell us some of the key points that you want the KevinMD audience to come away with.
I would say when we're making health decisions, follow the money. I think our peers are very important. We need to take the time to sit and talk to them about what's actually working and what's not. We used to have that time to hang out. Grand rounds were by master clinicians talking about what they've learned, not a drug company sponsored talking head about the latest drug. I think we want to look at the data out there that when we, especially in psychiatry, when the latest drug comes out, what really is the effect size? And it move the needle in terms of health outcomes? What is our goal? When you sign up, it's for a job, and nowadays it's so hard in most areas of medicine to be an independent practitioner. What are you giving up in terms of autonomy and choice? Things like non-compete clauses, which are
Mm.
maybe going to become illegal, but there's going to be ways around it. Like, be very careful. It's a slippery slope when you sign away the rights of your own ability to practice medicine as you think it should be, and the rights of your patients. That these contracts, business contracts, affect what you do in delivering your care. And I don't think we fully realize that when we get into it. And ultimately, doctors are becoming such a scarce resource. I think we have a whole lot more power than we know. I mean, we're enjoined from striking, and I'm not advocating that, but we've basically been sitting ducks because we won't do that and won't stand together as a group to say, no, this is not what our field is like, and this is what not how I'm willing to practice. I'm not going to enrich you by restricting this care to the people who are entrusting me with their life. In the business model, we don't intend to kill people. It's just a side effect of putting money over health.
Nicholas, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.